Welcome to Nursing 341 High Risk Neonates. In this session, we are looking at the intensive care of the newborn. And I'm Samira Ali Mustafa. Session overview. The Neonatal Intensive Care Unit is a specialized unit for the care of the ill and the premature newborn. And in this session, students will be introduced to the incubator, parts of the incubator, the care of the newborn in the incubator, and some complications that we have in the care of the newborn. Goal and objectives. At the end of the session, students will be able to describe the neonatal intensive care unit, identify types of incubator, and discuss its functions. Describe the care of the newborn at NICU, or Neonatal Intensive Care Units. For our outline, the key topics that we'll cover are the Neonatal Intensive Care Units, incubator care and its functions, common conditions managed in NICU, and then the management of the newborn in the Neonatal Intensive Care Units. So we'll look at, you have to read the chapter 21 of Wong's of Pediatric Nursing, which we have uploaded in Sakai for you. So here you have a picture of the Neonatal Intensive Care Unit. This is not typical of what you may have in Ghana, because you may not have an armchair for the mother to sit. But in high resource countries, you may have a place for the mother, even in the Neonatal Intensive Care Unit, to make them rest in there. However, in Ghana, what I've seen in hospitals like Ridge and Kolebu, there is a place where outside the intensive care unit where you have mothers coming to care for their newborns. So there is always space for the mothers to care for their newborn. It may not necessarily be in the units. So the neonatal intensive care unit is an intensive care unit for the specialized care of the ill newborn or the premature newborn. And this care is given by a team of healthcare professionals. So you may have the obstetrician or the neonatologist, and then you may have either midwives or pediatric nurses or some staff nurses who have also acquired the skill in the care over the years in working in the unit, and other physicians. And here they come together as a team to provide expert care round the clock. Because you know that as nurses, we run 3 shifts, 24/7. We are in there to care for the ill newborn. What is the purpose of this? The purpose for which we keep our babies in the neonatal intensive care unit is to maintain the temperature that mimics the uterine environment, to promote the development that they missed, especially in the case of the preterm infants. And then also provide the desired humidity and oxygen, because the device, the incubator, has humidifiers and also outlets for the provision of oxygen, and also for the observation of the skin, because the incubator is a transparent rigid plastic bassinet that allows you to view the baby through it. It also has ports or windows that allows us to care, and also affords us the opportunity to isolate and care for the baby in its own room as if it was in utero, to prevent infection and also protect it against other hazards in the external environment and unnecessary stimulations that will agitate the newborn. However, if you come to Ghana and you visit some of our neonatal intensive care units, because of limited resource, you see about 3 infants, different infants or newborns, I should say, in the incubators who come from different families. So to some extent, this isolation of the newborn in a separate incubator is challenged because of limited resource. Neonatal intensive care units, we have various levels. We have the neonatal intensive care unit for the purpose of caring for the seriously ill newborn, and then we have the high dependency care unit, where the newborns who seem to have recovered but still require some complex care are moved from the neonatal intensive care to the high dependency care unit. And then we have the specialized care unit where we also care for them to promote their growth. And this is in the case of the less seriously ill newborns. We transfer them into some of these units. So you see that it has some level of specialty in terms of the need of care for the newborn. We also have the transitional care. This happens just before discharge, and you may have to move the baby, let's say here, to a normal baby's unit. The baby is moved from the neonatal intensive care unit to maybe the ward where the baby is cared for, and the mother is also allowed to participate. So we're emphasizing on family-centered care, where the family or the mother or the caregiver is given the necessary skill to be able to continue with the care at home. And sometimes this means staying in the unit. An example is the kangaroo care unit, where we have that also in Kolebu, where the mothers are allowed to practice the kangaroo care when they have acquired the necessary skill before discharge. Then they go home and are able to take care of the babies without having them come back soon after discharge. Why is it necessary to nurse our babies in neonatal intensive care units? As we have already said, it helps us to provide them and support their development, and also give them the necessary care that they require because of illness. And so the incubators that are used, they give them that thermal environment that they require. And we have said that it takes a team of healthcare professionals. We have the neonatologist, the midwife, the pediatric nurse, and other physicians who come on board. And as I said, it's family-centered care in the sense that the family is involved in this care. And we involve them so they will know about whatever we are doing, and we seek their consent also, and also let them also have a say. This type of care, to some extent in Ghana, is still developing. So you may see that the parents may be involved, but not totally. But ideally, they should be involved and have a decision. But this family-centered care approach is still developing in Ghana. Indication for incubator care. We've said that all preterm infants need the incubator for the good humidifying environment, and also to prevent hypothermia, which is also one of the major causes of death. And the incubator also gives them the protection from infection in the environment. And the babies with low birth weight infants, and also babies who have some degree of hypothermic because of one encephalopathy or the other, some defects in the brain, and all ill newborns also need to be cared for in the incubator. So what is the incubator that we are talking about that we need to care our babies, use to care for our babies? We're saying that it's an apparatus that maintains the environment and conditions suitable for the newborn care. And you see that I'll be showing you in a few minutes what these incubators look like. But you see that it's a rigid box. Most of the time plastic, it is transparent, and it allows us to also view and observe our newborns who are under our care. Also, the device is also made to provide the other care, like it has a humidifier, so we add humidity to the environment so the air is not totally dry, because the oxygen we also give also predispose them to some degree of dryness. So the air that is in the incubator is humidified, so it's not just any dry air. We're also able to open and give care because it has windows and or ports, as you may call it, to allow us. And also we have said that it helps us to provide them with the necessary warmth, because it has a gadget that allows us to increase and regulate the temperature, and also provide some nutrition, where we have to give them IV lines or pass NG tubes. There is windows through which these catheters can be passed and given, and also allows us to administer medications. This is one type of incubator you can have. This is a giraffe warmer. So basically, it is open to the environment, as you can see, and it has an overhead heater. And this allows us to assess the critically ill during the period of care. So if you are doing an intravenous line or passing one catheter or intubating the newborn, and at the same time want to provide some warmth, this giraffe warmer will allow you to do that. It also can be used doing x-rays and the like. And the disadvantage this warmer has is that the baby is exposed to the environment and there is no control over humidity. So the environmental air is what circulates around the newborn. Another type is the natal care, intensive care incubator, as you can see in this picture. This is also a standard incubator with various options to meet the developmental needs of the highly acuity babies, that is the preterm that needs intensive care. So this is also another type. We have the care, this is called Care Plus 3000 incubator. And you see that this has some degree of advancements in technology, so there is some thermoregulation integrated here that allows us also to have opportunity through some valves or windows or ports to care for the baby, and it also gives us a precise environment for the care of the preterm or ill newborn. This is also another type called the INC 100 Neonatal Intensive Care Incubator. This has been also designed to provide the safest and the most stable environment possible for the critically ill newborn. It also has a wide range of accessories, as you can see from the picture. It's tailored to meet the care of the critically ill newborn. And this is also another type, the transport infant incubator. So as the name connotes, it's for transportation. So in cases where you have to, let's say, transport a baby from maybe the maternity or labor unit to the neonatal intensive care unit, this incubator provides the preterm with the necessary environment in terms of warm environment, humidified air, oxygenation, and all that, so that the danger of hypothermia and infection is reduced. So this is purposely for transportation from one unit or institution to another. This, I'm afraid to say, you may not have in Ghana, or if we have, they will be very limited. So how do we care for our incubators in terms of maintenance? There is a need to clean, there is a need to disinfect, and there is a need also to check for its functionality, whether it is in good shape, and these must be done daily. We have to clean the incubator with sterile or distilled water, and it also needs to be disinfected, so we can use Savlon that should be diluted, that we use to clean, and after that we further clean it with the sterile water, because if the disinfectant is too strong, it can predispose the newborn to also apneic attacks, and we have to assess that the humidifier, the thermoregulator, all windows and wheels, whatever cracks there are also fixed. So we have to ensure that everything works well before we put in any newborn to let it serve the purpose for which it was made. So what are some of the functions that we can have, even though we have said a few in passing? One major one is oxygenation, because it allows us to have oxygen supplementation in cases where the ill newborn or preterm infant, as we know, the lungs are not mature enough and may need support. So we may have to pass some catheter or prongs through the incubator. We may also have the CPAP, what we call the continuous positive air pressure, which comes like a hood or a cap over the head, or in cases where there is a need for mechanical ventilation, the incubator allows us to perform all these functions. And also in newborns who have some respiratory distress syndrome, as we will have in the preterm infant, because the lungs are not well developed and there is some inadequacy of surfactants. There is also health, which is a leading cause of death in preterm infants. It allows us to administer some surfactants and also ensure that we monitor the preterm or the ill infant continuously throughout our care. And it also allows us to be able to observe, because we've said earlier on that the plastic of the bassinet is transparent, and so we are able to view, and also it also has some thermoregulation, so we are able to adjust the temperature in the incubator that will support the respiration, cardiac function, and oxygenation and brain activity. It also protects the preterm or the ill newborn from infection and noise and excessive handling, because it is contained in the incubator, which is covered on all sides, except in the windows or ports that are open periodically to offer care. And also it helps us to maintain the fluid balance because of the help of the humidifiers. The air in the incubator is humidified, so it doesn't allow for unnecessary heat loss through maybe evaporation through respiration. Or we have also said that the preterm infant does not have the flexion, so it's all extended, so the body surface is exposed, there is lack of keratin on the skin, so there is a lot of fluid loss looking at the large surface area and then the transparent nature of the skin. So the incubator also helps us to prevent some of these fluid loss. We have also said earlier, and you have seen the transport form of incubator. So in cases where we have to transport the newborn from one institution or community to a larger health facility, the incubator also helps us to do that. And it also have outlets, as I said earlier, that we are able to pass through to administer care in the form of IV pump or pulse oximetry or even giving of oxygen. So we say that in the care of the ill newborn or the preterm infant, the incubator allows us to give some high acuity care to the ill newborn, because we have the ventilator support. We have also able to care for some newborns that might have undergone surgery, and then also any resuscitation that needs to be done can be done either with any form of the incubators available. It can be done through that, and it also helps us to advance our interventions and care by giving the right temperature and reduce the worsening the condition of the newborn through hypothermia, because that one will suck a lot of their energy and will predispose them to hypoglycemia and other conditions that will worsen their state. And throughout the period where the newborn will have to stay in the neonatal intensive care unit, let's say if it's more than a week or a month, throughout this time we are able to feed, we are able to give phototherapy in cases where there is some degree of jaundice, and also administer all other medications, including pain medication and antibiotics, because we have the windows to do that. And so some common conditions that we have that brings newborns to our outlets at the neonatal intensive care unit. Number one, we have said, is a premature or the low birth weight newborn. Another is the birth asphyxias, babies who have difficulty to establish respiration at birth and may need to be supported. It may also be as a result of meconium aspiration that is causing the birth asphyxia. And the newborns with some defects, birth defects, be it cardiac or anything that worsens the condition of the newborn. And then another key thing we have to look brings them is infection. And then neonatal jaundice and the respiratory distress syndrome, we have said, is a common feature in the preterm because of the immature nature of the lungs. Another common complication that we have, or the major cause of death that we have, is the necrotizing enterocolitis, what we popularly call NIC. And this is also as a result of maybe feeding and then not making sure that the baby is able to tolerate its bacterial infection that causes necrosis of the intestines. And this is also one of the major causes of death in our newborn. And also one of the complications that we may have, especially in the extreme newborn, is cases of intracranial hemorrhages. And there is also the danger of chronic bronchopneumonias among some of the newborns we care for in NICU. So we here will say that the prognosis to a large extent is good. However, the survival rates in Ghana vary from institution to institution. So once again, the outcome of newborns in terms of survival in, let's say, Kolebu Teaching Hospital, which is the nation's biggest hospital with the biggest neonatal intensive care, and therefore specialists, may not be the same as you have in a hospital like Ridge Hospital, which to a large extent is very crowded, and so there is also the likelihood of having more infections. And then you see that, and it also will vary pertaining to what you have in a hospital like the military hospital, 37 military hospitals. So once again, the overall survival rates in Ghana differ from institution to institution. So we want to look at some common problems that we have in the newborns that we have that brings them. So one common condition we talked about earlier is a respiratory distress syndrome. So there is a need, it's very, very important that every day we perform respiratory system assessment. And in performing this involves examining the chest to look at the shape, whether it's barrel or concave, to see whether there is a presence of chest tube. All these connotes that there is some difficulty. And also we will assess for the use of accessory muscles, whether the nerves are flaring or there is some intercostal retractions. All is telling or depicting labored breathing. So you have to assess for all these and then determine the respiratory rate and make sure that they are all within normal, and also auscultate. Now, emphasis is that we have to auscultate for breath sounds and not count them, because when you auscultate, then you are able to also hear in addition any additional breath sounds that you will not elicit by counting the respiratory rates. And some that you find in cases where there is some problem, you have wheezing, and then in the preterm we said you have grunting, but the grunting in this case is respiratory grunting, so note that. So some indicators here that shows that there is some problem is diminished air entry. So when you auscultate, you'll be able to elicit that there is some amount of diminished air entry, and then you also should be able to elicit or describe the nature of cry if the baby is intubated, because if it's very, very weak, then the cry will be virtually very faint, and so it will tell you that the newborn is very ill. And then describe the method of oxygen that we are giving, and then you must also do the pulse oximetry to note the saturation, so that if the baby is doing well, it can be weaned off. And then respiratory support here will require mouth care. Babies who are on respiratory support may require mouth care to prevent drying, because he said that that is one of the major effects of oxygen therapy. And then there is also the need to avoid routine suctioning, because it may cause bronchospasm. So you suction only when it is necessary in babies on respiratory support. And also, when we are changing the diaper, It is also very important that not only when we are changing the diaper, but all newborns, even adults who have some difficulty in breathing, we have to nurse them in the upright position. So this infant must, when we are changing the diaper, we should raise the infant slightly and then under the hip and then change the diaper. Okay, so I'm saying that we nurse babies with respiratory distress syndrome or who have difficulty in breathing in the semi-prone position. And it's important that we nurse them on the lateral on the side, that is the lateral position, to prevent aspiration with excess mucus after feeding. It's also very important that we give oxygen saturation according to prescribed amounts, because when it is in excess, it is known to cause some blindness and other side effects that may not be reversible. So we don't just open the valves, but we go according to prescribed amounts, and then also ensure that the thermoregulators are working to provide the neutral thermal environment required to also conserve utilization of oxygen, because if the baby is cold, it affects other organs. It's also very important that we assess the infant's response in cases where the baby has been intubated and is needing some form of ventilation or the other. So in cases where we have newborns with respiratory distress syndrome or some difficulty in breathing, some common nursing diagnosis one can formulate is ineffective breathing pattern related to pulmonary or neuromuscular immaturity. And the goal here will be that we will exhibit adequate oxygenation. I think this is how far we talk about, and then now we'll look at protecting the infant from infection. In our setup, we know that infection is a very common occurrence. So it's very, very important that all equipment that we care for or use in the care of preterm infants or ill newborns are sterile. So asepsis is key. And where we also nurse them in the incubators, we are saying that the incubators, the radiant heaters and all must also be cleaned daily. And also in between care, we must clean all these to ensure that they don't end up being source of infection. And then we must monitor, as I said, that these equipments are working as they should. The personnel must also be healthy. Any individual with infection should not be allowed to enter the neonatal intensive care unit and should not be involved in the care of any newborn with illness. So if the person is coughing or the person has cold or any form of infection, the person must not come into contact. And there is a need to use infection preventive measures like using the mask, wearing your gloves, washing your hands before and after care. And then if you have to move to another newborn, you don't transfer one newborn's items or objects to the other. Plastic tubings must also be changed regularly, and we must make sure that they are clean at all times. It is also very important that visitors who also come in, like family members, must also be free from infection. And then wearing of special uniforms, or I would say protective gowning before they enter the unit, or covering their hairs, and then wearing mask is mandatory, because we don't want to contaminate the environment in the neonatal intensive care units. So they may have to remove even the slippers from outside and wear indoor shoes provided by the hospital. And in cases where we have limited resources, As I said, there is a nursery area demarcated for the care of the newborn. The mothers may have to receive their babies, and they don't have to enter the neonatal intensive care units. And so it's very, very important that all disposable equipment are used as such and disposed of at the end of care. Hand washing cannot be overemphasized. We must wash up to the elbow. We must teach the mothers who care for their newborns to do the same. And there should also be minimal handling. So we handle only when it is necessary. The problem of overcrowding must be avoided as much as possible. But once again, in our setup, I've said that it is one of our major challenges. You have 3 newborns sharing one incubator because of limited resource. And then also breastfeeding is the best. The breast milk is the best for the newborn. So whether preterm or ill, we still have to encourage the mothers to express the milk, and then we in turn we keep it in the fridge and warm and give. It is the best. So where mother's health allows it, we should allow them to come and support, and by expressing the milk. And in cases where the baby's condition allows it, we must allow them to breastfeed. Skin care. Skin care, we must assess the skin every day for any sign of infection, be it redness, rashes, lesions, some form of excoriation or breakdown of the skin must be assessed daily, because we all know that the skin is the biggest organ and it's a major source of infection. We must also evaluate and report any findings that connote some abnormalities or will tell us that we report early and address, and also intervene accordingly. And then bathing. We're saying that in the extremely preterm or the ill preterm, our aim is to provide warmth and not predispose the baby to bath, a cold, true bath. So in case where the baby is transported from the labor room to the neonatal intensive care unit, it is important that we allow some time to elapse, at least 2 to 4 hours minimum, so the baby will recover before we give the first bath. And also when we are giving the first bath, we should use soap that is neutral and not very harsh, because you see some mothers coming with soap like Medisoft, which is a bit too harsh. So we want to use soap that is baby friendly. And for us midwives and pediatric nurses, we must note that the vernix caseosa, which is the white covering on the newborn baby, must not all be completely removed, because I have seen in practice some also put Vaseline and other preparations on the newborn before birth in attempt. In the ill preterm or ill newborn may not be able to tolerate this, and going about this a bit too actively or vigorously can affect the baby negatively. So we have to guard against it. And then bathing preterm infants less than 32 weeks should only be done with sterile water, because we want to prevent infection. So you see that it's basically top and tail. So routine bathing, we're saying that the frequency should be decreased. So basically what we do is to top and tail. So you just clean areas that needs to be cleaned, and then do a thorough top and tail. So the second or the third day, we do the top and tail. We clean the eyes, the mouth, the diaper area. So we clean where needs to be cleaned and not dip the baby in water and predispose the baby to hypothermia, which will worsen the condition. And then we also use soap minimal. So when we are using sterile water, you just clean once or 2 times in a week. Maybe you use the soap, but it should not be a daily practice, because we said we want to reduce exposure to the environment, and then also reduce bruising during bathing. So it should be something very gentle to clean, and it shouldn't be too vigorous. Once again, the soap we said should be, the pH should be neutral, so it shouldn't be any harsh soap. And then also the use of iodine and alcohol should be minimal. And when we do, we should also further clean the area with sterile water. This is best practice. But in our setup, because of the poor sanitation, we use some of these things without rinsing. But in best practice, these, after we have applied the alcohol, methylated spirit, we must further clean with sterile water. So some general observations we have to make. We have to check the vital signs. We have to assess the newborn for jaundice, pallor. We have to assess axillary temperature. We have to assess the baby's activity in terms of cry. And then we have to assess the heart rate and the respiration. Once again, we have to also address the cord and also assess for any sign of infection. We have to look at how the baby is feeding, the amount that is able to tolerate, and regurgitation. We'll have to assess the urine. We have said earlier that when the baby passes the urine and is in the diaper, we have to weigh the diaper whilst empty and also weigh it after the urine so we can assess the amount that, in terms of weight, that is due to the urine. And we have said that in terms of gram, 1 gram is equal to 1 ml of urine. So note that that is how we calculate it. And any abnormal signs like edema and hemorrhage, and then the nutrition, we have said that the breast milk is best for the newborn, and that should be given. It is in cases where this is not available that we may have to resort to other formulas. Otherwise, the breast milk is the best for the newborn, whether sick or well. And in cases where the baby cannot feed, especially under 32 weeks, where may need to pass tube, so we may need to pass tube to feed the newborn, and this can be done through the mouth. Here I have an assignment for you. It's a case we have baby KA, a premature newborn, admitted to the Neonatal Intensive Care Unit, NICU, shortly after it was born for further management. We said enumerate 6 common conditions that should be managed in the Neonatal Intensive Care Unit and describe how this baby will be nursed. So these are some references you can resort to help you make time to do the assignment given.